on Crohn's disease.
სანამეში უცხოელები ყველა ხმა არ მოიღეს.
აბა.
ყველა რომ გაიტანჯე ხალხი წავიდა. არა, ხუმრობ კი არა, ნახევრად ხუმრობ.
Crohn's is a chronic, intermittently symptomatic systemic inflammatory condition affecting the gastrointestinal tract. It also has extraintestinal manifestations and is linked to other immune disorders. That's why it's considered to have an autoimmune etiology. Although Crohn's can be localized to anywhere in the GI tract, the most common sites are the terminal ileum, the colon, and while only 10% affect the upper GI tract, and always with rectal sparing. Our case was a 32-year-old female who came to the emergency department with nausea, crampy abdominal pain in the right lower quadrant, and abdominal distension which had been progressing over 7 hours. She has a 10-year history of Crohn's disease. During her course of disease, she had intermittent watery diarrhea, obstructive symptoms, and a 20-kilogram weight loss over 3 months. She also complains of shortness of breath on physical activity, fatigue, pain in the hand joints, and itchy skin. She has a surgical history for perianal fistula and ectopic pregnancy. On physical exam, she had a low-grade fever and tenderness located over the right lower quadrant. Now, the diagnosis of Crohn's disease depends on its phenotype, the extent of the disease, and severity. If we have the following clinical findings and we suspect Crohn's disease, we can do additional laboratory tests. These include measuring acute phase reactants, ESR, CRP, leukocytes, and hyperalbuminemia can be a marker for nutritional status, for poor nutritional status, and there can be coagulopathy from vitamin D malabsorption. However, the definitive diagnosis and the gold standard for diagnosis is made with endoscopy and biopsy. This is a classic histological sample from a patient with Crohn's disease showing T helper 1 mediated non-caseating granuloma, which can extend to the entire bowel wall, so it's a transmural process. There's a non-specific inflammatory infiltrate, and there can be crypt hyperplasia. A new immunohistochemical technique stains alpha defensins in Paneth cells. Paneth cells usually occur in the small bowel. However, in Crohn's disease, they can also occur in distal segments. And this is known as Paneth cell metaplasia. These alpha defensins are responsible for regulating the microbial colonization in the bowel, and this further supports a dysfunction in host microbe interaction in the intestine. New imaging techniques include chroma-endoscopy. On the left, we have a normal ileum in a patient with, in a healthy patient. The next image is one in Crohn's disease. It shows a characteristic cobblestoning appearance, which shows skip lesions. There are areas of normal mucosa separated by stellate ulcers. And chroma-endoscopy, as we see here, uses a methylene blue dye staining technique to allow for accurate, which stains for specifically for dysplastic lesions, allowing us more accurate and suitable biopsy sampling. CT and MRI are used especially to localize the disease prior to surgery, for example, and also to detect if there are any complications like fistulas, strictures, or abscess formation. Here, as in our patient, there's inflammation in the terminal ileum, showing thickening of the bowel wall and a narrowing of the lumen. There can also be mesenteric fat adhesion to the inflamed bowel. 1/3 of patients with Crohn's disease show extraintestinal manifestations. This can range from arthritis, peripheral arthritis of the hand joints, or even axial spondyloarthropathy, and there can be more easily visualized manifestations like aphthous ulcer, which is just a continuation of the GI tract, pyoderma granulosa, which is a non-healing ulcer-like lesion, erythema nodosum, which appears on disease exacerbation and remits on therapy. And here's an ERCP image of primary sclerosing cholangitis showing a beading appearance of the biliary tract. This, of course, impairs the flow of bile from the liver, and it can lead to buildup of bile salts in the skin and histamine release. And this, as seen in our patient, leads to pruritus. Serology has a specific prognostic value for Crohn's disease patients. We can also use it to differentiate patients with Crohn's and those with ulcerative colitis, which is also an inflammatory bowel condition. As we can see, Crohn's has an increased titer of anti-Saccharomyces cerevisiae antibodies, which also plays which is also evidence for an autoimmune etiology in Crohn's disease. In terms of prognosis, high titers correlate with increased risk of complications and increased frequency of surgery. Now, Eleanor will now continue with the pathogenesis of Crohn's disease.
So, pathophysiology of Crohn's disease is largely unknown, but it involves several factors: genetic, environmental, and immunological. So what about environmental factors? Environmental factors combined with genetic predisposition in individuals may lead to development of Crohn's disease. And environmental factors may act on different ways. For example, NSAIDs and smoking increase permeability of intestinal membrane, while antibiotics and gastrointestinal infection alter composition of gut microflora. So it's important to know that the two best studied environmental factors are smoking and NSAIDs. Smoking not only increases the incidence of Crohn's disease, but it also worsens the course of the disease. And quitting smoking is one of the bad things that patients with Crohn's disease can do. So what about NSAIDs? After acute infection triggered by NSAIDs, we have in normal individual a repair of mucosal barrier and downregulation of innate immunity and T-cell response, while in patients with Crohn's disease we have chronic inflammation because of the impaired immunoregulation, failure of repair of mucosal barrier, and failure of bacterial clearance. This is Harvard research. Harvard researchers have found that there is an imbalance in microbial imbalance in patients with Crohn's disease. It's also, I want you to pay attention that antibiotics are often prescribed to patients with Crohn's disease, but it only worsens the situations as the microbial imbalance is pronounced, and we have antibiotic use actually make symptoms only severe and not relief. So, what about genetic factors? We have the first gene was associated with Crohn's disease is CART15, and it encodes NOD2. NOD2 is in class of bacterial recognition receptors, so it's located on cytoplasm and it binds to bacterial peptidoglycan. But in patients with Crohn's disease, which have homozygous mutation in NOT2 receptor, there is impaired bacterial signaling, so we have increased production of interleukin 12 as we see here, and it says T helper 1 response. I want you to pay attention to HSP17, which stands for heat shock protein 70. It's a chaperone molecule which helps NOT2 to follow the improper three-dimensional structure. So NOT2 is more stabilized and slower degraded if we treat patients with HSP70, but it's not clinically approved yet. So, first line of defense in the mucosal immune system is a single-layered polarized epithelial cells which are covered by mucous biofilm. Decreased expression of mucin gene, MUC1, suggests there is insufficient mucus cover. Also, paracellular neurotophlaxis between neighboring cells is normally blocked by tight junction, but in the case of Crohn's disease, tight seal becomes leaky. So, because of changes in the tight junction protein claudins, so antigens are increased in lamina propria, which is densely populated with immune cells. So we have uncontrolled immune response. And pilot cells are highly specialized epithelial cells which excrete alpha deficit that regulate makeup of commensal microbiota, and patients with Crohn's disease have 3 TA variants of the autophagy gene ATG60L, and this means they have fewer dysmorphic and functionally impaired alpha deficits than do the other variants. And the last one is XPP gene, autophagy gene, that leads to activation of endoplasmic reticulum stress and ectoplasmic reticulum stress, sense response of unfolding protein response, and it induces inflammation. So, in the normal immune system, antigens are first processed by mucosal epithelial cells and then presented to immune system. But in the case of Crohn's disease, as we have impaired mucosal barrier, the inflammation is set up. First, antigen-presenting cells activate inflammatory T helper cells, and inflammatory T helper cells produce increased amounts of tumor necrosis factor alpha. And tumor necrosis factor alpha is the major driver of chronic inflammatory activity in Crohn's disease because it binds in epithelial cells and macrophages and set inflammatory response. So, as we see here, we have anti-tumor necrosis factor alpha that binds tumor necrosis factor, but it's important to know that it's ineffective in 50% of patients. So, data supporting T helper 1, T helper 17 T-cell mediated process in Crohn's disease are particularly compelling. First, dendritic cells in lesional tissue produce master cytokines, interleukin 12, P70, and interleukin 23, which says T helper 1, T helper 17 response. Second, cells in lesional tissue also produce transcription factors, TET4, TBET, and RT, which is very, very important, which also said T helper 1, T helper 17. So the major inducer of T helper 1 cell producing interferon gamma is interleukin 12, and in controversy, interleukin 6 and transforming growth factor beta are major inducers of T helper 17 cells, while as we see interleukin 23 interacts with already differentiated T helper cells, and in the absence of interleukin 23, we have interleukin 10, which is anti-inflammatory cytokine. So why it's important? It's important because of anti-cytokine therapy. So here you can see that there are allogenic activity. So it's important also to note that tumor growth factor beta is involved also in regulation of proliferation of T regulatory cells. And in patients with Crohn's disease, we have overproduction of SMAD7 protein, which inhibits tumor transforming growth factor beta, and Mongersen inhibits SMAD7 overproduction. So as I already said, transforming growth factor beta regulates proliferation of T regulatory cells. So it's important to know that transforming growth factor beta and T helper 17 cells have some kind of yin-yang relationship. It means when the FOXP3, which is the transcription factor of transforming growth factor beta, is activated, there is inhibition of ARO-RC, which is transcription factor of T helper 17 cells. So the last thing I want to tell is that T helper 1, T helper 17 resembles delayed type hypersensitivity. This means that there is influx of macrophages and granulomatous lesion. In addition, because of T helper 17 cells, we have cryptitis and also neutrophilic infiltrate in lamina propria, which leads to thickened bowel wall, intestinal narrowing, obstruction, and etc. So Anna will continue with treatment of Crohn's disease.
Elena mentioned some future therapies for Crohn's disease, but they are currently under in clinical trials. I'll talk about the treatments that we use in every day. So the aim is to induce clinical remission, so the patients are relieved of their symptoms, and also to induce mucosal healing, which is the cause of the disease. 5 aminosalicylic acid agents are anti-inflammatory agents, and although they are used in mild cases of Crohn's disease, because they are only in a topical treatment, they're taken orally and to coat the mucosa. But Crohn's disease is a transmural process, and this isn't of any help in moderate and severe cases of Crohn's. Budesonide is also a topical steroid, and because of its high first-pass effect, it has minimal systemic corticosteroid symptoms. So it is useful, but there are other therapies which are more successful. Systemic corticosteroids are only used for acute flare-ups, and the dose needs to be tapered off to avoid the severe side effects like acne, Cushing, osteoporosis, and hypertension, diabetes, and others seen from chronic corticosteroid treatment. Antibiotics, the 2 which are chosen are ciprofloxacin and metronidazole. These are used if there is fistulizing disease, if there's abscesses. But as Elena mentioned, overall we don't choose this unless there is an actual infection in the bowel. And the principal therapy is anti-tumor necrosis factor alpha agents. And these have shown a very high success rate, especially as monotherapy or in combination with the biological therapies as a therapy, for example. However, before starting the patient on infliximab, we have to screen for tuberculosis, because tumor necrosis factor alpha is responsible for maintaining granulomas. And by inhibiting this, we can reactivate latent tuberculosis. If these therapies are unsuccessful, there are new ones, alpha-4 integrin inhibitors. Alpha-4 is located on the lymphocytes, and this is responsible for the entry of these cells into the bowel. So by blocking this receptor, we inhibit the entry of the inflammatory cells into the bowel. However, natalizumab is an alpha-4 integrin inhibitor, which is also has targets located in the brain. So there's a 1 in 1,000 risk of CNS progressive multifocal leukoencephalitis, which presents with multiple focal lesions in the brain. Vedolizumab is a newer agent which has more specific targeting to the gut. Surgery is a last resort. It's used as a last resort because even if the area affected is resected, there can be recurrence of Crohn's disease at the site of anastomosis. It's also preserved for if there's a perianal disease, and if the symptoms are not controlled with medical therapy, and as a result of medical therapy, if there are severe side adverse effects. Now, the prognosis is fairly good for patients with Crohn's disease, but of course it depends on the severity and the complications of the disease. Now, if the patients are in remission, they have the same mortality as the general population, which is good. If there are severe systemic symptoms, for example, more than 10% body weight loss, if there's a young age at diagnosis, if there's a high frequency of complications, of course, this has a high morbidity. It's also important for patients to undergo colorectal cancer screening 8 to 10 years post-diagnosis. This is a result of the chronic inflammation in the bowel, which is a foundation for tumor cell development. And this is done with colonoscopy and biopsy every 1 to 2 years. Thank you for